Hello, good morning, good afternoon, good evening, and welcome to our town hall on San Antonio Breast Cancer Symposium 2020, sponsored by Axiom Healthcare Strategies. We have a fabulous panel for you today, and we'll try to review the top-line data from San Antonio. I am Hope Rugo, a professor of medicine at the University of California, San Francisco's Helen Diller Family Comprehensive Cancer Center. And in just a moment, I'll ask our panel to introduce themselves as well. I want to point out to you that there is a Q&A button on the bottom of your screen, and you can put in questions into that panel, and we'll all be looking at them, and we'll try and address them in the overall panel as well. We have with us today an international panel, very exciting, and we'll start with introducing our international colleagues. Dr. Rebecca Dent, could you introduce yourself?
Hi, thanks, Hope, so much. Great to be here with everyone. My name is Rebecca Dent. I'm a medical oncologist at the National Cancer Center, Singapore.
And Dr. Trigliano.
I am Giuseppe Curigliano. I work at the University of Milano and European Institute of Oncology in Italy.
Dr. Nanda in Chicago.
Yes, I'm Dr. Rita Nanda. I'm a breast medical oncologist at the University of Chicago.
And Dr. Bardia Aditya.
I am breast medical oncologist at Massachusetts General Hospital, Boston.
And my colleague in breast surgery, Michael Alvarado.
Hi, thank you, Dr. Rugo. Michael Alvarado. I'm a surgical oncologist, a breast surgeon at UC San Francisco. Thank you.
Wonderful. Thanks very much, everybody. So our program today actually will be to go through some data and then to discuss it. And what we're going to talk about today is divided into breast cancer subgroups and modality of therapy. We're going to talk about triple-negative breast cancer, hormone receptor positive disease, and HER2 positive breast cancer. And then we're going to end with a couple of interesting presentations on radiation therapy. We're going to include in triple-negative breast cancer interesting data from immunotherapy and AKT inhibitor, 2 AKT inhibitors, biomarkers from the sacituzumab govitecan ASCENT trial. For hormone receptor positive breast cancer, of course, we'll talk about the early stage data with CDK4/6 inhibitors, as well as some fascinating data looking at genomic predictors in terms of how we're going to treat our patients with node-positive disease in clinic now. And then we'll talk about a new oral taxane and then updated data from a second oral taxane. For HER2-positive breast cancer, we saw exciting updates from the DESTINY-Breast01 trial with trastuzumab deruxtecan, another novel ADC. And then we saw some additional analyses from the tucatinib triplet HER2 CLIMB study. From radiation therapy, we'll talk about longer-term data from different radiation schedules and fractionation. So we're going to start actually with triple-negative breast cancer and Keynote 355. For the summary on Keynote 355, we are going to have, I think, Rita first talk about Keynote 355 a little bit, and then we'll discuss some of the implications.
Thank you, Dr. Rugo. So I think as you all are aware of Keynote 355, this was a randomized phase 3 placebo-controlled trial, which was the trial that led to the recent FDA approval of pembrolizumab for metastatic PD-L1 positive triple-negative breast cancer. And what we saw presented at San Antonio this year was an update of the progression-free survival data as well as duration of response data, which was really quite impressive. So as you'll recall, the approval is for PD-L1 positive triple-negative breast cancer based on a combined positive score of at least 10. And you can see here that there was a very impressive improvement in progression-free survival for the PD-L1 positive population and a trend to improvement in those with a combined positive score of greater than or equal to 1. So again, an impressive 4-month improvement in progression-free survival. Next slide, please. And you can see here, this was a pre-planned subgroup analysis, and across the intention to treat and both PD-L1 positive subgroups, there was a favorable outcome for those patients who received pembrolizumab in conjunction with chemotherapy. And you can see that in those patients with a combined positive score of 10 or more, that it was across all of the different chemotherapy arms, including paclitaxel, I think, which is very interesting to note. Although I will say that the placebo arm, so the chemotherapy only arm of the placebo randomized patients did do a little bit poorer than the other chemotherapy backbones. So I just point that out because it's interesting, although these numbers are really very small. Next slide, please. And we saw, again, the duration of response, 12-month improvement in duration of response for those patients who were PD-L1 positive, as defined by a combined positive score of greater than or equal to 10, which is really just very impressive, a 1-year improvement in the duration of response, with a majority of patients, so over 50% of patients, having a response to therapy. So I think this was really exciting data for us to see. Obviously, we're still waiting for the overall survival data, which I'm sure will be coming in the not too distant future. But I think, when I think about this regimen and I think about the flexibility of the different chemotherapy backbones and that really impressive duration of response, it's really exciting to have this option available for patients with metastatic PD-L1 positive triple negative breast cancer.
So that's really great and interesting summary, I think, of this data. We did see a difference in Impassion 131 that was presented at ESMO, where there was no benefit from adding paclitaxel to atezolizumab, despite the updated 7.5-month overall survival benefit with nab-paclitaxel and atezolizumab. Giuseppe, how do you interpret this data and how do you place them into clinical context?
Yes, for sure we have different results, but also the chemotherapy regimen used in combination with atezolizumab was completely different. We have nab-paclitaxel followed by AC. Here in the Keynote 355, we have the addition of Carboblatin. So the question is whether it's the addition of Carboblatin to increase the rate of pathological complete response, or is a different synergy between the immunocheckpoint inhibitor and the chemotherapy. So I really believe that all the studies, both of them, clearly show that there is an improvement in PCR rate. They are both very good regimen in the neoadjuvant setting for patients with, specifically with recurrent, inoperable, or metastatic triple negative breast cancer. And finally, the only difference that we can find here is the way we assess the PD-L1 expression. Because in the inpatient, we have finally a SP142 assessment of PD-L1 and should be more than 1%. Here, it's quite clear that with the CPS score, we have another type of assessment that maybe is more inclusive and can more enrich the number of positive cells.
It is an interesting comment. I think that, if you look at the PD-L1 CPS of 10 or more in 355 compared to Impassion 130, the numbers are almost identical. 1% or greater by SP142 is about 40 to 41%, and this is 38%. So it makes me think, although there's not complete overlap in our biomarker analysis of 130, that there is some similarity in these two tests when you enrich for PD-L1 using a higher CPS, because it certainly finds more patients to be positive if you use one. Rebecca, these are big questions about what chemotherapy partner you use in the metastatic situation, why Impassion 131 was negative, and how we choose the right partner moving forward, as well as the right checkpoint inhibitor. What are you doing in clinical practice now? And in your environment, patients have to make a big decision about paying for a specific therapy and even the test.
So Hope, I think it's a big question for a lot of places around the world. I'll say maybe outside the US, in fact, so as well as in Southeast Asia. So I think, certainly what I think is important is we now have 2 FDA-approved immune checkpoint inhibitors that really opens up the options. Now, I think if you're using your 22C3 assay and you're going to give solvent-based paclitaxel, you're clearly going to combine it with pembrolizumab. So I think if you have access to nab-paclitaxel, you can give it with either immune checkpoint inhibitor. My own gut instinct is that nab-paclitaxel is a superior taxane and certainly is easier to deliver with fewer toxicities. So it is my favorite taxane in the recurrent setting especially, but I think certainly these updated data with 355 really broadens up the opportunities for patients, because if you're already paying for pembro, then I think you have options with the companion chemo that are considerably less expensive, and you can give them with more confidence.
Really interesting. Aditya, what are you doing in Boston?
It's a similar approach as that of Singapore, which essentially is that for patients who are eligible for immunotherapy, the advantage with pembro is that you can use any chemo backbone, be it platinum or a taxane. And in the metastatic setting in general, if taxane is used, tend to use nab-paclitaxel. And in that setting, you can either use atezo or pembro. So the Impassion 131 really didn't change practice. We were using nab-paclitaxel with atezo, but now with the Keynote 355 data, you can use pembro as well. And the advantage is you can also use pembro with the platinum.
Yeah, it sounds like most people wouldn't use paclitaxel in combination with either checkpoint inhibitor, despite the data from 355. Rita, in Chicago, you've had more COVID than we've had in San Francisco, although we seem to have a lot right now. So this has changed everything this last month. But do you have any hesitancies about using checkpoint inhibitors in the COVID pandemic time?
I will say that I think the second wave has helped, not helped us, but we've learned how to manage patients a little bit better. So with the first wave, we really had scaled back who all was getting therapy or not. But I've actually, interestingly, had a number of patients on checkpoint inhibitors who've had asymptomatic COVID infections now. Unknowingly to me, they were treated with checkpoint blockade for their advanced stage disease and have done quite well. So, I think that certainly there are concerns. There's not great data in this space, but anecdotally, I have not had any issues. Most of my patients have been asymptomatic carriers of COVID. But, I think we're going to continue to learn. But we also know that triple negative breast cancer is a very deadly disease. And if patients can benefit from these agents, and I look at these amazing duration of response and overall survival benefits that are clinically meaningful, I think it all has to be weighing the risks and the benefits.
I think one question that's come up before we move on, and Frankie Holmes has asked, is in our Q&A, is whether or not the difference is due to paclitaxel trial, but maybe due to steroids. But interestingly, in 355, steroids were able to be used, and Carbo would have received paclitaxel, would have received steroids, and patients who were receiving Carbo would have received steroids, and steroids were used for moderate immune toxicities as well. So it seems unlikely. I don't know if anybody has any other comments about this, but if not, we'll move on to our next topic. So we're definitely seeing a lot of new agents, and we had talked about this quite a bit in terms of our treatment choices and hypotheses in terms of benefits or not. So I'll just leave that slide up just for a moment to show the approval of both atezolizumab and pembrolizumab. And just ask one more question of Giuseppe, does the survival difference seen in Impassion 130, albeit the negative data in 131, influence you to choose one checkpoint inhibitor versus another in terms of treating your patients?
This is a very good question, but actually, in Europe, atezolizumab is approved just in combination with nab-paclitaxel. So this will not affect my choice as a treatment for a patient with a triple negative metastatic breast cancer, PD-L1 positive, since until now we have just atezo approved. The opportunity to combine pembro with paclitaxel, with carbo and gem, will be, of course, a unique opportunity to treat other patients, because, it depends also on the type of treatment you receive it in the neoadjuvant setting and in the adjuvant setting. The major problem is the assessment of PD-L1 in Europe, because we have no reimbursement for SP142 and for the CPS score. So what we are doing now is to test all the patients, and then according to clinical history, we select or combination of atezo plus nab-paclitaxel, or selection of pembro in combination with carbogem or with paclitaxel eventually.
That's really interesting. I think it is fascinating, and it will be quite interesting over the next 2 years to see how this all plays out around the world in terms of how we use this. And of course, the survival data with Keynote 355 is expected next year, which is coming sooner than we really even can remember. But I'm guessing that in the US population, there will be almost 100% crossover to receive atezolizumab in the second line if you were randomized to the placebo arm. So it'll be interesting to see. So we have, of course, the first author and PI of the Opportunity trial, Rebecca Dent, who presented this data at San Antonio. Tell us a little bit about this interesting AKT inhibitor and the disappointing results.
Thanks, Hope. So as you know, the IPAT 130 study was meant to be the phase 3 confirmatory study based on promising results from the LOTUS study, which was a randomized phase 2 hypothesis generating study that included all patients that were triple negative, included though a biomarker positive group of patients. So those patients who had aberrations in PIK3CA, AKT1 or PTEN. And in that study, there were suggestions of improvements in PFS and trends towards improved overall survival. So based on this, IPAT 130 just included those patients that were biomarker positive. So that's using next-gen sequencing, FMI results. And so only those patients who were eligible had to be about a 12-month window since they're adjuvant chemo versus only 6 months in the LOTUS. And they were randomized to either receive paclitaxel or paclitaxel plus IPAT, and it was a 2-to-1 randomization. And what you can see here is in the primary endpoint was investigator-assessed PFS, median follow-up of 8.3 months. The improvement was from 6.1 months in the control arm with just solvent-based paclitaxel and improved to 7.4 months, which was not obviously clinically or statistically meaningful. Now, what's interesting to note there is the control arm being 6.1 months is almost double that of the control arm of Keynote 355 with solvent-based paclitaxel. So I think part of the reason is that these patients had to have the results from their FMI testing before they could be enrolled, which is easily about 3 to 4 weeks. Now that improved over time as the trial went on, but certainly I think that's why you're having a slightly better prognosis group there in the control arm. In terms of side effects, very similar to what we saw with the phase 2, meaning mostly diarrhea, and you can see there really no difference in terms of response or clinical benefit rate. Now, if you look at the next slide, why this is so interesting is that this exact same meeting, Peter Schmidt presented in a spotlight session mature data from the PAC study. So the PAC study, just like the LOTUS, which is the phase 2 study of the IPAT, was almost identical study design, but with capivasertib. And here they randomized again to paclitaxel versus paclitaxel plus capiva. The difference is the primary endpoint was PFS, but they also had the secondary endpoint of this biomarker positive patient population. And here what you saw was improvements in PFS, but improvements also numerically in overall survival. And this was sort of the mature survival data that was presented at San Antonio. And you can see they're improved from about 13 and a half to 19 months. And this was actually though in the ITT population. So, I think if you go to the next slide, I think there's still, as Hope put to me at the meeting, could we just advance one slide? What are we going to do now? What's moving forward for AKT inhibition? And I think, it took us a long time to identify a PIK3CA inhibitor in ER-positive breast cancer. So I think maybe we're a bit too optimistic to think that first confirmatory trial, we would see a result. But I think the first thing that we have to remember is that triple negative is a very heterogeneous disease. And certainly we can't control for all the possible confounders. Certainly we know that AKT inhibition has effect on the immune system, remodels the microenvironment, and we did see some imbalances in PD-L1 expression, but also it means that maybe we're not going to see benefits in PFS, but also maybe look towards OS as we do in IO. And so I think, we will wait for some of that OS data. We are doing some really interesting translational work. We already saw some clues in the phase 2. We'll look at that in the phase 3. We certainly have more tissue and more blood. And I would encourage people to enroll in the Capitello study, because this study, different from the IPAT study, is in all comers. It's a very large trial, like 800 or 900 patients in the ITT. And I think it's important to have a biomarker positive and negative population. And I think maybe some lessons can be learned from IPAT that we can apply to this study.
That's really interesting. I mean, this whole concept of looking at the biomarker negative population and that maybe you skewed your results results by looking at the biomarker population identified in the LOTUS trial is interesting. Obviously, we'll see what happens with Capitello, because my guess is that enthusiasm may drop off for enrolling into the trial. But Aditya, is there another targeted agent that you are looking for with a lot of excitement like this? A small molecule will add to chemotherapy?
I think there was a lot of excitement related to AKT inhibitors from the LOTUS trial and the PAC trial, and I very much agree we'll need additional follow-up to see if the overall survival data would give a hint, particularly given the role of PTEN loss in mediating resistance to immunotherapy, and AKT being downstream could have an impact. So it'll be interesting to see longer follow-up both from the Opportunity trial as well as the results from Capitello. The other thing to consider would be both of these drugs, capivasertib and ipatasertib, are pan-AKT inhibitors, and we've learned from the PI3 kinase field that alpha-specific PI3 kinase inhibitor versus pan-PI3 kinase inhibitors does make a difference as far as the adverse events are concerned. And would there be a similar principle for AKT inhibitors as well, that you need AKT1 as opposed to a pan-AKT inhibitor? So additional work needs to be done. But in terms of pathway, this is clearly a pathway that's overexpressed in a subset of triple negative. So it would be good to continue investigating therapeutic approaches to target this pathway.
Yeah, very well said. Giuseppe, is there another novel agent that you're really looking towards? I mean, I think that most of the agents now are in earlier phase trials. I can't think of another phase 3 trial that's really looking at a novel agent added to standard chemo.
But you know, the other trial that is ongoing is the EPIC trial in PI3 kinase mutated triple negative breast cancer, comparing nab-paclitaxel frontline versus nab-paclitaxel plus alpelisib. Of course, is a specific pathway. We know that some triple negative breast cancer are PI3 kinase mutated. You cannot combine with paclitaxel because the use of steroids will increase the risk of hyperglycemia. But the idea to combine with nab-paclitaxel, I believe, is very interesting because the subpopulation of triple negative breast cancer are PI3 kinase mutated. So let me see what will happen in this trial also.
Yeah, I think that trial is quite interesting, and also it'll be interesting to see how the toxicity is managed over time, although the dose of alpelisib will be a little lower. There's been also interesting data using AKT inhibitors in hormone receptor positive disease, with some intriguing data from the phase 2 FACTION trial with capivasertib, and now a number of ongoing phase 3 trials. Do you think that's a better pathway to investigate with these inhibitors, Rita?
Yeah, I mean, I think that it certainly makes sense. We know that the pathway is relevant for a wide variety of different forms of breast cancer. So I think, you know, it will boil down to efficacy and tolerability. And obviously with some of these agents, there are tolerability issues.
And then Rebecca, back to you again. You know, one of the questions that came in from John Yoder is that why not continue to explore AKT inhibitor, checkpoint inhibitor, and chemo? I think, you know, there are pragmatic decisions that are made that we might not necessarily make as investigators, but there was, as you know, some intriguing data presented at AACR by Peter Schmidt in 2019.
Yeah, so as part of the IPAT 130 study, we actually have a cohort C, which is evaluating the triplet. And so I think there's no question that I think we're going to see synergy between immune checkpoint inhibition and AKT inhibition, again, because of this remodeling of the microenvironment. And certainly in the phase 1 data, it was there were some really impressive responses in these patients. So I think, you know, we'll look forward to seeing some of that cohort C data, likely sometime in 2021.
So, and that's not a phase 3 trial, though.
It's a single arm phase 3 to sort of establish some more data on efficacy and safety that was added later in the sort of halfway through the study. We added the cohort C.
That's great. Yes, I actually still have an anecdote. I still have a patient on Opportunity who was in the cohort receiving ipatasertib, because after the data was released, we were allowed to unblind. We already knew she was on it. It's pretty hard to unblind these agents, but she had limited node disease and has a CR, and she's still on the drug. We stopped the chemo a long time ago, so she's still taking it. We talk about it every time she comes in. So I think. Go ahead.
That's the most interesting thing I think about the compound and people that have given it a lot. I think what you probably see with immune checkpoint inhibition, it's not like you see these fabulous responses, but then you know that afterwards the natural history of the disease changes. And that's exactly what we saw in Lotus and we saw in IPAT 130 is that, it wasn't like you saw these amazing responses, but then after they progressed, they were living a really long time. And I think that's why, we are keen to see OS data. We are keen to see the Capitello data, because I do think it's fundamentally changing the natural history of the disease because of its effects on the microenvironment. I think we've really underappreciated this with a number of agents.
I'm certainly think that there may be some difference within the biology of the triple negative population who respond to AKT inhibitors and don't, that we aren't measuring, kind of similar to the very long survival we saw in the control arm of the Impassion 131 trial in this PD-L1 positive group of 28 months. My patient, she's an older woman. She has a much more indolent form of triple negative disease. It's, I think, guessing maybe less of a basal-like, resistant population. And maybe if we could identify those patients, they would be the patients who really benefit from this approach. It's at least my hypothesis for what it's worth. Just to mention before we move on to the next, is that there are quite a number of randomized trials using both ipatasertib and capivasertib in hormone receptor positive metastatic disease with fulvestrant and no marker required with fulvestrant following the progression on aromatase inhibitors, and then in a triplet type of treatment with ipatasertib with a CDK4/6 inhibitor, which I think is quite interesting based on preclinical data. So both of these trials are currently enrolling patients. And I think just lastly, as we go forward is, did you, Rebecca, very quickly know some questions from the Q&A boxes, the biomarker population of triple negative breast cancer who have these alterations, if there's a difference in primary and metastatic tissue, and if there's any reason to test those now based on these data?
So it's about 35%. And actually, it's interesting, these mutations appear to be quite stable. So in a lot of these trials, some of them are early, some of them metastatic, and it doesn't seem to differ. The other thing is in terms of the tissue and the blood, there seems to be very good concordance. We had 100% concordance looking at the activating mutations. So PIK3CA AKT in the phase 2, we had 100% concordance. But right now, I'll be honest, other than clinical trials, we don't really have any data to suggest that we should be testing for those. I think probably you're just doing your next gen sequencing, looking for trials, looking for other things. And certainly we're now looking for other drugs that are now available and looking at TMB and other potential fusions and stuff like that. I think there's many other targets that are coming through that are tiny percentages of TNBC, but I think it's still worth doing.
Yeah, very, really interesting as we move forward. We have to, delve into narrow populations. So Aditya, the ASCENT trial, which you presented at ESMO this year, and is really exciting data in heavily pretreated triple negative breast cancer, did an additional analysis both based on TROP2 expression and presented in addition a little bit of toxicity data. Can you tell us a little bit about that new information?
Yeah, absolutely. There were a couple of abstracts presented at San Antonio related to ASCENT. One was the biomarker abstract, the other was the safety tolerability dose reduction abstract. In terms of the biomarker abstract, the team looked at two biomarkers, TROP2 expression, as well as germline BRCA status. So as a brief reminder, ASCENT trial was a phase 3 trial comparing sacituzumab govitecan, which is a TROP2 antibody drug conjugate against treatment of physician's choice for patients with metastatic triple negative breast cancer. And essentially, from a biomarker perspective, there was interest in looking at TROP2 because that's the target of the antibody drug conjugate. And what was interesting was that the biomarker really didn't predict for lack of benefit. So patients who had TROP2 high expression versus TROP2 low expression or TROP2 medium expression in all the three subgroups, patients who received sacituzumab govitecan had better response rate and progression-free survival as compared to the control group. So there was really no predictive value of analyzing TROP2. The other interesting thing is that the TROP2 high expression was seen in majority of patients. More than 50% of patients with triple negative breast cancer had TROP2 high expression. A subset had medium and low. And if we look at the numbers, there appears to be a trend that tumors that have high expression of TROP2 have higher response rate and longer PFS with sacituzumab as compared to the TROP2 low. But in terms of predictive value as compared to chemotherapy, all the subgroups derive benefit from sacituzumab govitecan. So it doesn't really change how we use the drug. In terms of looking at germline BRCA status, there was the hypothesis that tumors that have altered DNA repair pathway or patients who have germline BRCA mutation would have higher response to sacituzumab govitecan. But similar to TROP2, there was really no difference in patients with germline BRCA mutation status versus wild type. So bottom line is that the drug was approved in the FDA a few months ago for patients with metastatic triple negative breast cancer, regardless of biomarker or BRCA status. And the biomarker results from ASCENT confirm that. The final thing I would say in terms of safety tolerability is that the results that were presented at San Antonio by HOPE essentially emphasize that the major side effects seen with this agent is neutropenia and diarrhea, but those can be managed with the use of antidiarrheals as well as GCSF use. Patients who had a dose reduction, their outcomes were similar, if not slightly better than patients who didn't have a dose reduction, just emphasizing that patients who get a dose reduction are able to stay on the drug for a longer period of time. And then finally, in terms of the Ugt1a1 analysis, as a reminder, SN38, which is the backbone of this drug or the toxic payload, is metabolized by Ugt1a1, and there are polymorphisms in Ugt1a1. So in the ASCENT trial, the impact of Ugt1a1 polymorphisms and AEs was evaluated. And overall, there was not a major signal in terms of AEs, but in terms of the severity of AEs, there was a trend that patients who had polymorphisms in Ugt1a1, so essentially the 2828 allele, they had higher incidence of febrile neutropenia as compared to patients who have wild type Ugt1a1. So it might be something that predicts for higher AE incidence, but whether it's ready for clinical practice, I don't think at this time. In patients who have neutropenia, you can always dose reduce or use GCSF. So to me, the biomarker results as well as the safety results confirmed what the FDA had approved earlier, that this agent could be used in the third line plus setting, regardless of the biomarker. You start with 10 milligram per kilogram, but if patient is having an AE, neutropenia, or some other side effect, then you can reduce the dose to 8 milligram per kilogram.
That's really helpful information, and this I thought was quite fascinating. Do you, Giuseppe, do you have this drug available to use?
No, we don't have this drug available actually in Italy. Of course, we hope to have it because having a so important improvement in overall survival, it's really an opportunity for our patients.
And Rita, have you been using sacituzumab? What's been your clinical experience?
Yeah, I've actually used it a fair bit. I have a pretty large triple negative population, and one of my patients who participated in ASCENT has been on this for over 2 years. And this is a woman who didn't respond to anything before, multiple lines of chemotherapy, even immunotherapy, although whether or not the immunotherapy she had in the past might have, helped her have a more prolonged response, but completely life-changing for this woman who really had run out of options. I found it to be very tolerable, obviously can dose reduce if need be for toxicities, but really just has been a game-changing drug for a number of patients with really very aggressive disease that's not responded well to anything. So,
and do you find that most of your patients need growth factors?
No, actually, many of them don't. So I've had a handful of patients. I have a large African-American population, and there's a component of ethnic neutropenia that we can sometimes see. So I have on occasion needed to use growth factor, but for many patients actually can manage them without.
It is a really interesting question. I think another question comes up about whether or not Erica Shimada asked if you would use sacituzumab before PARP inhibitors if a patient had a germline BRCA mutation, because potentially, you see survival benefit with one and not the other. And if you had a patient who is progressing on a checkpoint inhibitor, would you move this up to the second line as opposed to waiting? Rebecca, do you want to comment on that?
I think Aditya really wants to answer that question.
Yeah, I'm
But
sure.
so first I just want to say I'm proud to say that I had my first patient on sacituzumab this week, and thanks to colleagues on the line for some guidance there. I was very happy to see Aditya's genotyping data, but I think we should do that data in Asia, where we know that there are some alterations that do impact toxicity, and we've been giving irinotecan for years. So I think I'm very much keen to see because as we know, the study was only conducted in a few countries in Europe and the US, and so as we expand to other countries and we may see some pharmacogenomic differences in terms of toxicity. So just wanted to put that plug in there. So related to what I moved this up earlier, I mean, I think the big question is there anything unique about the patients who reach sort of later line setting, under the selective pressure of different treatments? Is this likely to be more effective? I don't think there's any evidence to support that. I'd be interested to see what Aditya thinks about that. I think certainly there are a ton of trials moving up into earlier line setting combinations with IO. Do we need to combine it with IO? But I think we're interested to see that. I think for now, I think, a lot of countries are very much, restricted to whatever the drug's been tried in. So I think for now, we mostly use it in the setting that it's been tried. And then I think we do trials to get a better sense, because certainly PARP inhibition, IO works better earlier. This drug seems to work later line. And so I think for now, we'll probably use it in the way it was, the trial was done.
Really interesting. And I know that, sometimes response to the first line can drive what you give in the second line setting. One of the questions that also came up was whether or not we should stratify by TROP2, given the data that you just showed, Aditya. What do you think? I mean, is it a prognostic factor? I mean, if you look at the slide that's up there, it's a little bit hard to say, because if you look at overall survival, it looks like the low and TPC are relatively similar to the high and medium combined. But is this something we should be stratifying for?
I don't think at this time. The numbers are pretty small. There were only 27 patients who had low TROP2 expression and were treated with SG, so the confidence intervals are pretty wide. Something that could be investigated in the future, but I don't think at this time someone who has TROP2 low triple negative breast cancer should not get SG. I think all these subgroups derive benefit as compared to chemo.
Yeah, I think that that's a really important point. And also that based on what you had told us, we wouldn't be recommending that people be tested routinely for Ugt1a1 polymorphisms. And interestingly, different from Rita, I've also given a lot of the drug. Almost all of my patients are on growth factors, if not all, I think, by the time they get to the 6th to 8th cycle. And I think that's a tribute to really giving a lot of exposure. And now in the hormone receptor positive population in the Tropics trial as well. So I think, a really exciting new option for our patients. And we've talked about some very interesting results. We're going to move on to hormone receptor positive breast cancer, of course, the most common cancer that we see in really any setting, early or late stage disease. So our first area of discussion is to discuss Monarch E, and Giuseppe Carigliano will be discussing that for us first.
Yes, absolutely. The Monarch E was updated with the data during the San Antonio meeting. If you remember very well, the Monarch E enrolled patients with HR positive, HER2 negative, node positive, high risk early breast cancer. The definition of high risk was really particular. So we have an inclusion based on clinical pathological risk factors, more or 4 lymph node involved. And in case of 1 to 3 lymph node involved, there was an histological grade 3 and a tumor size more than 5 centimeters. It's really important to remember this for the definition of high risk. In the cohort 2, we have inclusion based on Ki67, 1 to 3 axillary node involved with centrally tested Ki67 more than 20%, not grade 3 and tumor size not more than 5 centimeters. And there is also a poster discussion session on the Ki67 that I will mention in my discussion. So 5,600 patients have been randomized to receive abemaciclib plus standard endocrine therapy from 5 to 10 years, or standard endocrine therapy alone. The patients have been stratified according to prior chemotherapy, menopausal status, and region, and the primary endpoint was invasive disease-free survival. And the key secondary endpoint was invasive disease-free survival in Ki67 high population, so more than 20%. So if we look at the data, the number of invasive disease-free survival events were 232 in the population of patients with endocrine therapy alone, and 163 in the abemaciclib plus endocrine therapy, with a statistically significant and clinically meaningful improvement in invasive disease-free survival. So the 2 years invasive disease-free survival rates were 92.3% in the abemaciclib plus endocrine therapy arm, and 89.3% in the endocrine therapy with a 3% delta difference. If we look at the distant relapse-free survival in the intent to treat population, we have also a benefit with the number of distant relapse-free survival events of 193 in endocrine therapy alone, and 131 in abemaciclib plus endocrine therapy. Also in this case, we have a clinically meaningful reduction in risk of developing distant mets, with the greater benefit in the analysis when we compare abemaciclib plus endocrine therapy. The 2 years distant relapse-free survival was 93%, and it was 90% in the endocrine therapy alone. Moving at the data with Ki67, we can see really that invasive disease-free survival in patients with high Ki67 was better for patients receiving abemaciclib plus endocrine therapy. And here we can see the data, because finally we have 82 events in abemaciclib plus endocrine therapy, with a 2-year invasive disease survival rate of 91% in abemaciclib plus endocrine therapy arm, and 87% in the endocrine therapy arm. We had also update on discontinuation of abemaciclib due to adverse events. Of course, it was more common to have a discontinuation in the abemaciclib plus endocrine therapy arm. I would like to mention the poster that Nadia Harbeck presented related to Ki67 as a biomarker for identifying patients with high risk early breast cancer. And in this poster, finally, it was quite clear that looking at the data in patients with high Ki67, independently on the number of nodes, 1 to 3 or more than 4 nodes, it was quite clear that there was a benefit in terms of risk reduction. So this is the first time that a pre-specified threshold of a Ki67 more than 20% has been used to prospectively evaluate the utility of central Ki67 assessment in a phase 3 registration trial. And among patients with high clinical pathological risk factors, patients with high Ki67, defined as more than 20%, had an even greater risk of recurrence than those that with low Ki67, confirming the prognostic value of Ki67. So the results of this poster clearly show that Ki67 more than 20% can be used together with nodal involvement, tumor sites, and grade to identify patients with HR-positive disease and HER2 negative early breast cancer at high risk of recurrence.
That's great. Very interesting. I mean, I thought this was it'll bring up a lot of discussion, but we also saw data right afterwards from Penelope B presented by Sibylla Leubel. Adichie, do you want to briefly tell us about that data?
Yeah, absolutely. It was back-to-back presentations, first from Monarchy and then Penelope B. So this was a trial looking at a different CDK4/6 inhibitor, palbociclib, in a slightly different setting. So this trial essentially was more like a CREATE-X trial where patients with hormone receptor positive, HER2 negative breast cancer had received neoadjuvant therapy. And if there was residual disease defined as CPS score of greater than 3 or greater than 2 with positive lymph nodes, were randomized to receive palbociclib with endocrine therapy versus placebo with endocrine therapy. And what was very interesting about the study results was that while overall the study was negative, if you look at the 2-year mark, at 2 years, there was a separation of the curve. Patients who received palbociclib had a 2-year recurrence-free survival of 88% versus 84% in the control arm. And if the data had been presented at 2 years, we would have said that this is a positive study because of the separation of the curves. But with additional follow-up, and congrats to the team for doing that, at 4 years, there was essentially no difference in the disease-free survival. So the curves came together. So it's pretty interesting, and I think highlights the point that with CDK4/6 inhibitors in ER-positive breast cancer, where late recurrences are not uncommon, longer follow-up is critical to see if the curves continue to separate versus if you're just treating micrometastatic breast cancer.
Yeah, it's really, I think, a big question, and these are coming up in our question box as well. What I'd like to hear from everybody is whether or not you think this is enough data to use abemaciclib, even though there's no regulatory approval for it. It is certainly approved in the metastatic setting and could be available to your very high-risk patients. Given the data from Penelope-B and of course from PALLAS, which is listed here, and we won't go through in detail, different risk populations here, different discontinuation rates with the highest in PALLAS, shortest exposure in Penelope, and differences in the CDK4/6 inhibitors, although we don't really know what to make of that. And I think in this question is, should we use abemaciclib? Do you think that we're just delaying metastatic presentation, or are we going to cure some of these patients who are destined to relapse early? Rita, what's your thoughts on this?
No, I think it's an interesting question, and all these data, trying to put them together is very interesting too. But I have to admit, in my very young women with very suboptimal response to neoadjuvant therapy, if they're mammoprint high, for example, and I've given them chemotherapy and they have multiple positive lymph nodes in a RCB 2 or 3, I absolutely would consider trying to get access to abemaciclib for these individuals. I think it's hard to know if we're really just treating micrometastatic disease and these patients will then ultimately go on to develop metastatic disease, but at a later time point. But I would argue that that's still a benefit for these patients. And so I think at this point, I would, particularly for patients who have, would fulfill the criteria for Monarch E, I would absolutely try to get abemaciclib if I could.
And Rebecca, would you?
So I have to say, I'm a little weary of the data. I think accepting all the caveats and differences between all the studies, what I really want to have a better understanding of is what these drugs actually do. It's been talked about, is it just treating micrometastatic disease? People saying, should we treat longer? Well, to me, that suggests that, what are we achieving? Are we actually getting apoptosis? Are we just causing the cells to sleep a while? I think, if you've seen some of the neoadjuvant data, I'm a little weary that we're just actually delaying relapse. And I think these patients that get ovarian suppression and AIs already in the adjuvant setting are really suffering. So I think we kind of owe it to patients to dig deep and to get a much better idea of who actually benefits. I think we're starting to tease that out, but I am still a little bit weary that we just don't know who those patients are.
And of course, there's always questions about, the cost of these drugs as well as the toxicity. Patients do feel more fatigued. There's certainly the now Natalie trials looking at 3 years of ribociclib, and those patients have to come in a lot and get their blood drawn. It's a really whole nother world, but I think that question is really important. So Aditya, are you giving abemaciclib?
Not at this time. It's not approved currently. Question does come up, and for a young patient with stage 3 disease, it's something that definitely needs to be discussed with the patient, but it's not approved, so we're not routinely using abemaciclib, but for an individual patient, you have to make the decision on a case-by-case basis.
And Giuseppe, I don't think you have it available in Italy for adjuvant use, and maybe can't sneak it in quite as easily as we can in the US, but would you give the drug if you had it available?
In a very high-risk patient with very poor prognostic features, including also high Ki67, also delaying metastatic disease can be really a good opportunity to give a drug like this. I agree with you. We don't know if we will cure those patients. This is the major question. So we need a longer follow-up to see overall survival data. But, if you have a very high-risk patient and would you like to escalate treatment to propose something more, you discuss with the patient. And if patient preference will tell to you to do this, I would give abemaciclib in this patient population.
Yes, I agree. Here in Cowboy Land in California, we take the same approach. So we're going to move on to a really big area, actually, to talk about our exponder and the ADAPT trials, actually, and how they impact our treatment of patients who have node-positive early stage breast cancer. Rebecca, can you tell us a little bit about this data?
Sure, thanks, Hope. So this is the RxPonder data from the SWOG group that was presented by Kevin, and basically it looked at 1 to 3 node positive patients that were ER positive, HER2 negative. And I think of any of the data presented at San Antonio, I would say it was the most clinically significant and practice changing, without a doubt. So really this is sort of the first data in the node positive population that is really there to help give us more confidence that we can de-escalate chemotherapy. So these patients were pre and postmenopausal. They were patients we normally think about giving chemotherapy to, had recurrent scores of 0 to 25, and they were randomized to either receive endocrine therapy alone or chemotherapy followed by endocrine therapy. Now, if you look at efficacy by menopausal status, you'll see in terms of invasive disease-free survival, which was the primary endpoint, there was no difference in terms of IDFS in the postmenopausal patients. So at 5 years, we have a 91% IDFS rate, which is really quite impressive for 1 to 3 nodes, no difference in the postmenopausal group. So I think in that group, patients 1 to 3 nodes, postmenopausal, score less than 25, I think we can safely say we can omit chemotherapy and obviously spare these women the short and long-term side effects of chemotherapy. Now, in the premenopausal patients, here we saw a difference in terms of absolute difference in IDFS of about 5.2%, so 89 to about 94%. Now, a lot of discussion around this, is the benefit related to the cytotoxic benefit of chemotherapy, or is it potentially the effect that it potentially has in rendering a woman menopausal by suppressing ovarian function permanently or maybe temporarily? And so I think there's been a lot of discussion about this. I think I have a hard time sort of teasing this out. I think very reassuring to us, though, that even in 1 to 3 nodes positive, these women had an excellent prognosis, almost 90%, even those that just had endocrine therapy. And so the other abstract related to this was the ADAPT trial by Nadia Harbeck, slightly more complex study, but again, was further there to give us support that there are a group of patients that we can potentially omit chemotherapy. But here it was a hybrid of mixing the recurrence score and Ki-67 response, so a response adapted model. So they looked at 0 to 3 nodes positive. They were giving these women neoadjuvant therapy, giving them endocrine therapy. And basically they looked at the patients that had recurrent score of 0 to 11, and then looked at patients 12 to 24 and had this drop in their Ki-67 after 4 weeks of neoadjuvant endocrine therapy to less than 10%. And what they showed is that the 5-year DFS was very similar between those two groups. So again, I think it just gives us a little bit more of an idea that there are groups of patients, despite being node positive, that we can omit chemo. It didn't tell us much about the 12 to 25 that didn't get the response less than 10%, but I think it tells us we should be thinking about these adaptive designs to escalate and de-escalate.
Thanks. That was an excellent summary. And Michael, from a surgery perspective, how do you put this data into context? How would you see this impacting patient quality of life? And then would you routinely want to have patients get exposure to endocrine therapy before surgery?
Yeah, I think this is obviously impressive data, and it helps downstream effects that sometimes people don't realize with regards to surgery, the surgical approach, and especially in the axilla. Classically, if a patient undergoes neoadjuvant chemotherapy in these settings and don't have a complete response, there's a high likelihood that they'll both get an axillary lymph node dissection and post-mastectomy radiation. So in those patients that are undergoing mastectomy, and as you know, and as the panelists and the participants realize, there's a significant amount of morbidity associated with that. So I think identifying the lower risk patients based on biology, as shown in these 2 studies, avoiding potentially the neoadjuvant chemotherapy, going straight to surgery, there may be more options for sparing downstream local treatments as well with regards to post-mastectomy radiation. Obviously, there's been a lot of data that Terry Maminis has presented and published looking at biology as a way of predicting local regional recurrence as well. So I think it really does have some downstream effects in terms of quality of life. And I'm very happy with this. As you know, Hope, we utilize these, you and I together, a lot in the postmenopausal patient population. And I think this just adds to what you've been doing and thinking in the past.
And, to me, it's interesting, the ADAPT trial, actually, that Nadia Harbeck, the hormone receptor responsive population, it looked like the group who had 3 positive nodes, although there was a very tiny number, did really significantly worse. And so I guess the question to you, Rita, is if in your clinic on Monday morning, so to speak, although Monday's already happened after San Antonio, would you treat a premenopausal woman with a Ki-67 response who had a score of 11, who had 3 positive nodes with endocrine therapy alone, or do you feel like there's not enough data yet for that group?
I feel like there's not enough data yet for that group. I mean, particularly if we're talking about very young women, I again would, just based on the Responder X data as well, I think the standard of care should or at least the discussion of chemotherapy should still be had with these premenopausal women with node positive disease. I feel very reassured by the Responder X data for our postmenopausal patients with 3 or fewer lymph nodes, but for the premenopausal population, I still feel like I want to see more data in the space. It could just be that the sort of difference is going into menopause either chemically or temporarily with chemotherapy, but I think until we certainly know that, I think it's hard to sort of make that change just yet.
And Aditya, do you have a different approach to that?
I would agree with our responder. There was a benefit in the premenopausal setting, not just with recurrence-free survival, but a trend towards improvement in overall survival. So I would not feel comfortable just omitting chemotherapy without a discussion with a premenopausal patient. But for postmenopausal, I think the data clearly connects both the responder and ADAPT, that recurrence score does predict biology, and potentially those patients could be spared chemotherapy.
Yeah, it's interesting. Actually, I think your colleague Halberstein has thought really that the translation of the premenopausal benefit in our responder is all due to ovarian suppression. Would you be willing to bank on that, Giuseppe, or do you agree with your colleagues?
We don't know really if the effect is related to chemotherapy or to the endocrine effect of chemotherapy inducing, let's say, an ovarian function suppression. But if we look at the data also of the MIND-ACT trial, there is a clear benefit also in this population of the MIND-ACT from chemotherapy. So I agree with Aditya, I would give chemotherapy to those patients with premenopausal status. We don't know really if this is an endocrine effect of chemotherapy or really a benefit of chemotherapy. But since we don't know, I prefer to do more in this context.
Well, so let me ask one other last question of Rebecca. If you have a patient who has 38 years old, has 1 positive node, no other high-risk clinical pathologic features other than the node, and has a recurrence score of 2, what are you going to treat that patient with?
So I think if she's strongly ERP or positive, and you have that oncotype score, I think I would also like to see her grade and her mitotic count. I would have a discussion with the patient, to be honest. I mean, I think all of this is speaking to the fact that we need to understand more biology of disease. And I think this is just the beginning. I think we're going to get more and more tools that are going to help us tease this out. But I think, every once in a while you are going to get one of those patients. And I think you have to talk to the patient because, that's pretty low score.
Yeah, I am actually myself, to give my opinion, I've actually treated patients like this with low recurrence score with ovarian suppression and endocrine therapy. And I started doing it a long time ago because I think one of them is 10 years out. So I definitely currently feel like that data is really supporting this. And I think we've answered the question by Kevin Cooney about chemotherapy and 3 positive nodes and a recurrence score of 23, where I think all of us would give chemotherapy.
Yeah. Yeah.
So let's move on and talk in our last little part here about hormone receptor positive disease before we move on to HER2 positive disease and radiation, about oral taxanes. And this is a really exciting new area. We're waiting to hear the FDA thoughts on these trials. So Rita, could you briefly talk about the Contessa data and the updated data from OPAC plus E or Oraxel?
Yep. So the Contessa trial was a randomized phase 3 trial. It was an open label trial that randomized women or individuals with metastatic hormone receptor positive, HER2 negative disease who'd received up to 1 prior chemotherapy for their advanced stage disease to the combination of tacitaxel plus a slightly reduced dose of capecitabine versus capecitabine monotherapy. And all of the patients in this trial had to have received a taxane in the early stage setting, either the neoadjuvant or adjuvant setting. They could have had a number of prior endocrine therapies and were required to have measurable disease. And so this was the first presentation of these data. We saw the progression-free survival as well as the response rate data. There was a 1 month in, there was a 4-month improvement in progression-free survival for those individuals, 3-month improvement in progression-free survival for those individuals who received combination therapy as compared to capecitabine alone, and this was significant. It's also important to recognize that 90% of the patients who participated in this trial were receiving this treatment in the frontline metastatic setting. There was also a higher response rate for the combination, I think not unexpectedly, as well as a higher disease control rate. And both regimens were quite tolerable, as we might expect a higher hand-foot incidence of hand-foot syndrome in those patients who received higher dose capecitabine versus the combination, and then more neutropenia, grade 3 to 4, as well as febrile neutropenia in those individuals who received the tacitaxel, the taxane in combination with the capecitabine as well. So I think minimal alopecia was seen with the oral tacitaxel taxane. It's a once every 3 week, pretty convenient oral regimen, and I think really just favorable toxicity profile, convenient drug to give with less neuropathy and less hair loss than we see obviously with the IV taxane. So I think these were interesting data. Moving on to an update of the oral paclitaxel and Sequidar trial, we saw an update of the progression-free survival analysis as well as overall survival analysis. And you can see there was a modest improvement in progression-free survival of about a month, but a much more meaningful 7-month improvement in overall survival, I suspect likely due to the ability for patients to remain on therapy longer. The one thing I would mention about this regimen is it can be quite cumbersome to administer. As someone who's now used it in the neoadjuvant space in the context of a trial with the fasting and the daily 3 days in a row and then every week can sometimes be a challenge for patients, the fasting requirements. But again, another option here compared head-to-head to IV paclitaxel. So I think a little more in line with what we're used to seeing. So really, I think impressive data. 2 oral taxanes now, one a little bit, I would argue, more convenient than the other, but studied in combination and not as monotherapy in the context of a comparison to IV paclitaxel, which I hope will be done subsequently.
Yeah, very interesting. And as you mentioned, we're now using OPAC plus E in combination with even with Carboblatin and checkpoint inhibitors in the neoadjuvant setting in the randomized phase 2 iSpy trial. So we're getting some experience using that drug. And I have patients who've been on tacitaxel capecitabine, albeit dose reduced, now for substantially longer than the median PFS here. Kind of interesting. Almost all of my patients are on well over a year with some neuropathy. So what do you see the advantages of oral taxane therapy are? How are we going to use this in clinical practice, Rebecca?
So we actually done the tacitaxel trials mostly, and I think we've got almost 30 patients on these trials. So I have to say my patients love it. And I mean, during COVID, we were just recruiting like crazy. So there's no question the oral administration, decreasing the frequency of visits, less alopecia. I think the only thing is I'd say in terms of its myelosuppression, we're seeing it's a bit more like docetaxel and the fatigue. So, especially the combo with CAPE, I think seeing the combo with IO, it's much better tolerated. So I think, it's not exciting or sexy, but for patients, it's a huge advantage. And for, chemo suites where, we're having a big issue in terms of space and things like that, I think in terms of the relief on the system, it's really quite essential. I just don't see a registration pathway for tezitaxel, so I'm keen to see how that will go about. But I think without a doubt, I see a real sort of advantage of an oral once a 3-week dosed drug for patients. Hopefully
Yeah,
the
I
price
agree.
point will not be absorbent, but.
And I think the reduction in neuropathy is really, really important for both of these agents. So exciting. And Aditya, Giuseppe, do you have anything to add to that?
I would just say that it would have been nice if the Contessa trial had a design like Ugt1a1, such a clean design of IV Taxol versus oral. And if tezitaxel had shown results that are even similar to this one, that would be a clear winner. The challenge is the design that was done with Contessa, but tezitaxel seems to be a nice drug, very convenient.
So I agree, I completely agree, and it's a huge opportunity for our patients to have an oral medication and to avoid intravenous administration every week or every 3 weeks. So it's convenient for our patients.
Yes, and it's great. And neuropathy, of course, is a huge issue, I think. And I agree that it would be nice to see like the drug Liporaxel being studied against paclitaxel. It would be nice to see tezitaxel, and I'm guessing that there will be some data on this in the not too distant future. Do you think if tezitaxel is approved by the FDA, they met their primary endpoint, would you give it only in combination with CAPE, or would you give it as a single agent, Rita?
Yeah, I think that's a challenging question there. I think that it would be unclear if we would see that same efficacy when not given in combination, but deep down inside, I feel like probably sequential single agents are going to be just as good as the combination, but I think I'd likely favor giving it in combination as it was given.
Yeah, I think that's really interesting. I can see us, sort of dropping the CAPE after a short bit and using tezitaxel alone every 3 weeks oral dosing. But these are really interesting. And next year will be the year to potentially have regulatory approval for these oral taxanes. So it'll be impressive. We're going to move on and talk about HER2-positive breast cancer. Actually, although this is an area where we've seen enormous advances, and actually just had in the last day another agent 2 days ago, I think, approved margetuximab, a novel Fc engineered antibody. So we've had actually 4 drugs approved in the metastatic setting this year for HER2-positive breast cancer. It has to be a record. So we're going to talk about the 2 of the updates and maybe just briefly mention the Nala trial if we have time. So first we'll start with the update of the Destiny Breast-01 trial, I think a phase 2 trial that's really had huge impact. Giuseppe, do you want to just summarize that?
Yes, of course. This is the update of the Destiny trial that used trastuzumab deruxtecan in HER2-positive metastatic breast cancer. I just would like to remind that the median number of previous line of treatment in this study was 7, so from 3 to 25. So it's quite important to remember that it is a heavily pretreated population. And the data of 184 patients confirmed the benefit in progression-free survival. It's close to 19 months. And also a benefit in probability of survival. It's close to 24 months. So if we add also the data of response rate, if we remember it was close to 60%, this is really an outstanding trial. I would like to remember inflammatory lung disease that requires awareness via monitoring dose interruption and modification. And 3 additional cases of related ILD have been observed in the trial. So I would like briefly to remember that ILD and pneumonitis can be a fatal outcome in patients receiving trastuzumab deruxtecan. So patients should be advised for the risk of ILD, and doctors should monitor signs and symptoms of ILD, cough, dyspnea, fever, and other new or worsening respiratory symptoms. So if you have a grade 1 that is asymptomatic pneumonitis, you should stop treatment with trastuzumab deruxtecan until resolution of any adverse reaction. And in case of grade 1 after steroid treatment, you can start again treatment. In case of grade 2 or higher, so symptomatic pneumonitis, treatment with trastuzumab deruxtecan should be permanently discontinued, and corticosteroid therapy should be initiated as soon as possible. So just remember this potential side effect of trastuzumab deruxtecan.
Thanks very much. And before we discuss this, let's go on and talk about HER2 climb updates. And I think Aditya, you were going to discuss this for us and maybe add a little bit in about the updated NALA data. And I think there was some data on Extenet, but I think we'll focus just on NALA here.
Yeah, absolutely. So as a reminder, the HER2 climb was a study looking at tucatinib in combination with trastuzumab capecitabine versus placebo trastuzumab capecitabine, presented at San Antonio last year, along with the Destiny-01 results. And this trial was a bit different in that patients were required to have brain MRI at baseline, and this trial did include patients who had brain mets. And interestingly, showed activity of tucatinib in patients with brain mets. To me, that was the most exciting component related to tucatinib. The drug is now approved. The update provided at San Antonio with additional data showed that patients who have CNS mets continue to derive benefit with tucatinib. The team also presented the results stratified by the hormone receptor positive status. And as a reminder, in the Extenet study, which looked at neratinib, the improvement appeared to be higher in the hormone receptor positive group as opposed to the hormone receptor negative group, maybe because of crosstalk between ER and HER2. But in this trial, which is in the metastatic setting, so it's a bit different, showed that there was essentially no difference in progression-free survival in the hormone receptor positive versus negative group. So the benefit with tucatinib was seen in both hormone receptor positive and negative groups, similar hazard ratios. In terms of overall survival, there was a trend that maybe in the hormone receptor negative group, the benefit with tucatinib is higher, but it's tough to interpret that without understanding what patients received post HER2 climb. So the therapies that patients received after tucatinib, which could have an impact on overall survival, that data is needed before we can really understand what the overall survival results mean. So to me, the results were very encouraging, again, confirmed that tucatinib is an active agent in patients with brain metastases and an option for patients with HER2 metastatic disease. In terms of neratinib, that's another agent that has activity in patients with brain metastases. And in San Antonio, I think the results were presented with 3 patients with leptomeningeal disease who also had HER2 amplified metastatic breast cancer derived benefit with neratinib. So that's another agent that has demonstrated activity in patients with brain mets.
Thanks very much. That's really interesting. Yeah, I think, leptomeningeal disease is just an impossible sort of end site of metastatic disease when there are cells in the CSF, as opposed to the imaging LMD that somebody asked me about recently. I said, no, that one's okay. But I think, there's some trials going on looking at tucatinib and certainly neratinib in patients who have LMD. So we'll see more data on that. Now we have trastuzumab deruxtecan. We've all worked really hard to say. And tucatinib in triplet for patients with metastatic HER2 positive disease, and now margetuximab, as well as neratinib. What order do you use these drugs in if they're available to you? And how do you manage if you don't have if a patient can't afford it or can't get the drug? Rebecca, do you want to start with that?
Sure. So I think the first thing I have to say with the TXD data, I like saying it that, it's easier to say. I think the thing about that compound that I think was really, as Giuseppe pointed out, is in heavily pretreated patients, was really quite impressive, the waterfall plots. And I think the most recent data at San Antonio was the durability of the response, because often we can achieve a response in heavily pretreated patients, but it's just not durable. As we sort of see our patients, we get excited, but to see a response that lasts 20 months or more is really quite impressive. And then they showed that the pneumonitis really wasn't cumulative. So I think that was, to me, extremely reassuring. So I hope to move TDXD up earlier. I think both of these compounds, to be honest, need to be moved up earlier. I think we're hopeful to see some TDXD data in the CNS as well. Certainly for tucatinib, I think we really want to move that up as far up as possible as we can, because they're really impressive improvements in survival and brain metastases. Now, we can bring both of these drugs in with special approval because of the Orbis program. We get FDA approvals quite quickly. We just have to get the companies to bring in the drug. Insurance companies will pay for it, but it's about getting the drug in a timely fashion, quite honestly, for us. And obviously it's going to be cost to get it to a broader group of patients. So hopefully the companies can work on that as well.
we have certainly a lot of issues with, evaluating chest CTs and chest X-rays now in the era of COVID, although with all the vaccines, maybe it will be reducing, we'll hope, fingers crossed. But Rita, how do you manage that? And would that impact, this ILD risk of the 2.7% mortality in Destiny Breast 01, albeit at a time when people didn't understand the risk and how to look for it largely? Would you choose one versus the other first at this time?
I have to say, in the handful of patients where I've had to make that decision, third line setting, obviously in brain metastases, particularly if someone's progressing after SRS and we're trying to delay whole brain or not do additional radiation, I would favor the tucatinib-based regimen, just given the impressive efficacy that we've already seen. That's not to say that TDXD is not going to have efficacy in that space, but I think the tucatinib data are really quite robust, and we know these patients can do quite well with tucatinib-based therapy. So I think that certainly is one factor that I take into account. If there are issues with reimbursement or how, not reimbursement, but how patients can afford tucatinib. And I have had a few patients who haven't been able to afford their copay. Then I think it's a no-brainer with the TDXD. It's IV, it's once every 3 weeks. It's, quite convenient in that sense. And, these patients are getting monitored, serially with X-ray, CT scans. And if there's any concern or issue around shortness of breath in this sort of COVID era, a pretty low threshold for re-imaging. So I think for me, I generally favor tucatinib-based therapy in those with brain mets where I'm trying to avoid any sort of radiation because we can see such nice dramatic benefits there. And I think beyond that, they're both very reasonable options. If somebody hasn't had capecitabine, either are on the table. So, I've used both and been very pleased.
Yeah, that's interesting. And I think, we're going to learn a lot more about ILD and how to have early detection and education for the patients, and our care teams are incredibly important in terms of patients who call in with symptoms or have changes on their chest X-ray or CT. Giuseppe, last question before we start move into the radiation therapy area. Margetuximab was just approved in the US. If you had it available in Italy, would you use it as after these two agents in combination with chemotherapy?
After trastuzumab deruxtecan or tucatinib, no, I would use before, personally. So overall, you have the opportunity to use margetuximab also following progression to the dual blockade. So, it depends on the extent of the disease and the burden of the disease. It's a very challenging question, the one you are doing. I am quite sure that if you progress in the post-neoadjuvant setting plus following TDM1, I would select tucatinib, capecitabine, and trastuzumab as a first option. But in case of progression to the dual blockade with no large burden of disease, maybe you can consider margetuximab. If you have a large burden of disease, I would go for trastuzumab deruxtecan. Because you have an impressive rate of response, and so you can improve symptoms of the patient very fast.
Really interesting. Well, so now let's go on, and Michael Alvarado, who's, of course, didn't ask to comment on treating metastatic patients, understandably, is going to talk with us about radiation therapy and some of the interesting presentations that were presented, since we all really need to be able to talk about this with our patients and help with decision making. So Michael, tell us some about this long-term follow-up of the PRIME2 study that's shown here.
Yeah, sure. Thanks, Hope. So both of these next two studies are really more data to go along with what some previous data has been shown in these different areas. So the first one looking at invasive breast cancer, and as similar to the CLGB study that's already been presented and published, looking at women in the 65 plus age group randomized to either radiation, whole breast radiation, or no radiation. Originally, we have to remember that these original trials were done mostly started back when we were offering women 5 to 6 weeks of radiation therapy. So it really was a big difference between, going every day to the radiation facility Monday through Friday for 5 to 6 weeks versus no radiation at all. So de-escalation with regards to local regional therapy. And now this is a continuation of the Prime 2 data from the 5-year data, but looking at 10-year outcomes now, and basically showing what we have known with CLGB in the previous Prime data, that women in this age group with what we would think of as considered low-risk breast cancer, small tumors in the under 3 centimeters, or closer probably mostly to under 2 centimeters in this trial, grade 1, grade 2, no lymphovascular invasion, and lymph node negative, but basically showing that there's no difference in overall survival with regards to these patients that undergo radiation versus no radiation. And then, as we would all expect, biology is very important, not only in the adjuvant setting for systemic therapy, but in local regional treatment as well. And as you can see on this slide, obviously those women that were estrogen receptor negative had a much worse outcome with regards to local regional recurrence. But similar to the CLGB data, local regional recurrence without radiation in these patients was roughly about 10% at 10 years. Similar to that CLGB study, and then with radiation dropping it down into the 1% range. So again, obviously, as we all know, radiation benefits everybody, but it really depends on the starting point. And here, especially in the era of COVID, giving women the option of no radiation, I think, is a perfectly great example. And I think what we have to remember as well is that there are changing dynamics with radiation now with long-term data for intraoperative radiation therapy as well. So there's a number of options for women in that area. The second study here is now looking at DCIS patients. And again, something to add to some body of evidence in the invasive cancer realm, looking at changing from a 5-week regimen for whole breast radiation to a 3-week or hypofractionated. And a little bit more complicated in this trial, because not only showing hypofractionation in terms of 3 weeks versus 5, but also incorporating a boost for patients as well. And as what we would all expect, the most important aspect, I think, from my thoughts and my colleagues, is that, as would be expected, hypofractionation, the 3-week course, does just as well as the 5-week course for these women with DCIS. So again, this is great, adds to the body of evidence, and also probably a lot of radiation oncologists in this country have been doing hypofractionated or 3-week course for DCIS, but this really does give them the data to show that it does work as would be expected. Now, interestingly, again, the concept in this trial of non-high-risk DCIS really incorporates a lot of women that probably might do well with even less therapy. As you all know, in terms of the participants and the panelists, that we are moving towards identifying women to do even less therapy for DCIS. So I think this just adds to that concept that we can de-escalate for women with DCIS. They will do exceptionally well, and we can move forward with even probably further de-escalation in offering women no radiation, 3-week courses of radiation, or potentially even others. And finally, I think what's really important, and unfortunately I think it's late to the game, but looking at local regional biology. The oncologists, obviously on the panel, as well as in the participants, have been utilizing biology with regards to genomic assays now for a long time to help tailor treatments, offset treatments, de-escalate. And now finally, all of these trials that you see here utilizing genomic assays to really look at the biology for these patients to determine what the best adjuvant therapy is in the local regional setting. So really tailoring local regional therapy, whether it's radiation therapy here, as you can see, but even surgically now, thinking about what we can offer women in the future with regards to genomic assays. So I think it's a pretty good data here to give us more options for women potentially to do less.
That's great. A wonderful summary. And I think so interesting. It's nice to hear what was updated in terms of sparing our older patients radiation. and in how to really try and better understand the biology of DCIS and treat patients less intensively who don't need it. Really makes a big difference. Those days of seeing patients who have bilateral mastectomies because they have a 1 centimeter low-grade DCIS, I hope, are mostly over. So that's nice. I think as we close here, we just have a couple of minutes left. I'd love to just get one sentence. Our one sentence is really hard about the data you thought was the most practice changing at San Antonio for you this year. So let's start with Rebecca, because it's the earliest in the morning for you.
Depending on how you look at it. So, I think, as I said for my, when I reviewed the RX Ponder data, I think, we've always had this gut instinct that there was a group of ER positive patients that don't need chemo. Now we have, Taylor X, we have RX Ponder, we're having increasing amounts of data to support these decisions clinically. So I think that's going to help me sleep better at night. It's going to help me inform patients, make better decisions. So that would be my top choice.
Aditya.
No, I agree. Less is more, and biology matters, and RX Ponder confirmed that. So it's good to have a non-chemotherapy options for our patients.
Rita?
I have to agree. I think that was the practice changing, or I guess confirming how we practice at trial for me at this meeting. But I also have to say I was pretty excited to see the development of the oral taxanes and how the neuropathy and alopecia is lower with these agents, and getting excited about moving those agents up into the neoadjuvant space, particularly as I take care of a large minority population. African-American women are more susceptible to neuropathy. And so I think that will be a huge advantage down the road, a number of years from now, but I think forward thinking.
Well said. And Giuseppe?
Having the opportunity to escalate chemotherapy in patients with 1 to 3 lymph nodes postmenopausal, it's great. So for me, RX Ponder was the most important one.
And then Michael.
Yeah, in all honesty, I agree with that 100%. I think, seeing patients that come outside of our institution for discussions about surgery and potentially, as a neoadjuvant patient, and me thinking that I really don't think you need the chemotherapy, I wish we had this data. It really does help now for me to see those patients and kind of push back on those oncologists outside of my own institution. So I'm super grateful for this and for our patients.
Well, I'm actually very grateful to have all of you on a video program here to talk about the best of San Antonio after we've had a week to sort of think about and digest the data. This is just an incredible discussion. And I really hope that we can all be together sometime next year, but this is the next best thing. It's really such a privilege to be surrounded by so many smart and wonderful people in this field of breast cancer, and to see the remarkable advances we've made. I know that people in some parts of the world don't have access to all of these therapies, or even any, and some to the genomic tests as well. But we hope that this data still helps you in managing your patients in terms of translating the information into your own clinical practices and looking to the future. I want to thank the panelists, and I want to thank Axiom Healthcare Strategies for putting on this really excellent symposium. Thanks for listening.